Assalamu alaikum. Welcome everyone on board. Actually, yesterday we started doing some basic concepts related to ICU. I will just quickly recap and then we will just cover some specific topics. Okay. What I wanted all of you regarding this is that in ICU, our general approach is the same for any patient. There will be some surgical or medical indication. Okay. Like any patient who will be like needing optimization or some unwanted event occur. So that patient will be coming to ICU or HDU. Anyone knows what is difference between ICU and HDU? Yes, anyone would like to tell? Because if it is interactive, it is better. Nashida, would you like to tell? Okay. Actually, if it is only requiring one organ system other than ventilation, okay, so it is in HDU. But if, for example, if it is needing more than one organ system, it is ICU. Okay. So organ system means, for example, if the patient is on inotropes, okay, so this is one organ support. If also patient is on CRRT, okay, so now two organ systems are required involved, so it should be in ICU. Or in even if it is one system, but it is mechanical ventilation, so it will be ICU. Okay, this is one thing. Then we discussed that how to evaluate a patient with reference to central nervous system, cardiovascular system, respiratory system, okay, and hepatic system, okay, liver, this one, kidneys and endocrine and metabolic, okay. So we just said that there will be certain common things that if you are having any neurological problem, we will be looking at the level of sedation, reflexes. So there will be certain criterias like Ramsey scale, GCS, AVPU scoring system, okay, for an evaluation of central nervous system. And then cardiovascular system, there is some problem in my uh, I don't know what is happening. And anyways, so the in cardiovascular system, we will be actually looking at the blood pressure, heart rate, and circulation. But we will be looking at whether this cardiovascular system is automatically maintaining itself, or we need to give some inotropes, vasopressors. Okay. So similarly, respiratory system, that whether patient, what sort of oxygen patient is taking, like patient is taking with the this one oxygen mask or ventilator or things like that. Okay. So please mute your mic. Okay. So then we discussed that what sort of medication patient will be on. So we discussed that usually the patient is on antibiotics. Okay. Patient is on inotropes, vasopressors. Okay. And patient is on some ulcer prophylaxis. Okay. Some steroids, some like electrolyte replacements. Okay. Then also patient uh, are on some at some times laxatives or enema. Okay. So the other like this is just an overview. Then there are some protective things which we are doing for the protection of either sepsis or VAP. Okay. So we just took an general idea, and today we will just try to see some of the important topic. Like, for example, if I start with sepsis. Okay. So what are the different, yes, Dr. Bajiha, you want to say something? Dr. Bajiha, would you like to say something? You rose the hand.
नो इट्स ओके मैं जो ना मतलब वो नहीं हो रहा था मुझे ऑडियो नहीं आ रही थी इस वजह से मैंने रेज हैंड किया नाउ इट्स ओके
Okay, so Dr. Memuna, are you free to talk?
Yes, sir.
Yes. So what is sepsis?
Sepsis is defined as life-threatening organ dysfunction due to dysregulated host response to infectious agent.
Okay, is it related to infection or no?
Yes, it is dysregulated host response to infectious agent. Yes, it is related to infection.
Okay, so actually, generally, the terminologies which used to be there are what is SIRS, what is septic shock, what is severe sepsis. Okay, so there were some changes in the latest sepsis management guidelines. Okay, so before they used to rely on SIRS. So what is QSOFA? Now they are dealing it on the basis of QSOFA. So what is QSOFA scoring?
It is basically includes three parameters: heart rate, respiratory rate, and sorry, it's not the heart rate. It is basically mean arterial pressure or systolic blood pressure, GCS, and respiratory rate.
Okay. So what was difference between SOFA and QSOFA?
QSOFA is basically the clinical assessment. We don't need labs to calculate the score, and it
Yes, the
has so.
principle was they just try to avoid the delay in the start of management. Okay. So they will be saying that this patient is at risk of infection. So they will be starting on the lines and then they will change it. So what are, for example, if you have a patient with suspected sepsis, what will be the first thing to do? Like you say that Q SOFA is just pointing out that there may be element of sepsis. So what is the first thing to do?
um, uh, Treat it as a medical emergency with 1 hour bundle, which includes the and of course by ruling out and searching the other infectious and non-infectious causes as well to rule out to find out the source of that probable sepsis. So I can then enlist the about the 1 hour bundle.
Actually, you know,
If you
I will just suggest you are absolutely, your answer is absolutely perfect. But if you just think about it, that if you answer in a ABC manner, that will be a better answer. Okay. You don't need to specifically just mention about 1 hour bundle. Okay. I think it is a better way that you will be saying that my approach will be airway breathing circulation, and I will be immediately taking the IV lines, and because whatever you are doing for 1 hour bundle will also be including that thing. But usually we forget while answering. Okay. So I think still you can you label it as a medical emergency, am I right? Okay. So it is better if you start with, because the first step is identification. My actually this writing is not I'm trying to try again. So actually, first thing is to identify, okay, and then immediately ABC, and then you can say that I will send the blood culture. I will send the lactate. I will send the labs, like whatever, for example, not only blood culture, if you are suspecting urinary tract infection or you are suspecting any wound infection, so you will be sending the cultures and you will start the empirical antibiotic. Okay. And then you are starting the fluid therapy. What will be the first fluid to be started? Yes, Mamuna? Or anyone wants to speak out? Nashida, would you like to say something?
Crystalloid fluid.
Okay,
Crystalloid. Ringer lactate. 30 ml
crystalloid
per
fluid,
kg.
ringer lactate in normal saline or ringer lactate?
Ringer lactate now in recent 2021 sepsis surviving sepsis guideline. 30 ml per kg ringer lactate within 3 hours, of course, depending upon hemodynamics of patient.
Okay, so you when you are seeing the fluid, you can say some other things that you can take intra-arterial blood pressure monitoring. You can start taking this one intra-arterial blood pressure monitoring or CVP if you are suspecting that this patient may be needing vasopressors. Okay, this is another thing, and then you will be, because one thing here at the same time is identification of any possible site of infection. Like if there is something, some wound debridement is needing, then you will say at the same time. Okay. So what else will you do?
For source control.
Yes, yes, of course. If the patient is needing after initial stabilization, if there is obvious source of infection, okay, then you have to involve the surgical team and you have to get it, because otherwise all your efforts will be futile. Am I right? Like for example, if you have a patient with the diabetic foot, okay, so after initial stabilization, the management is the debridement. Am I right? Or later on, if it is gangrenous, then amputation. According, this will not be your decision, but you have to tell. Okay. Similarly, if they are asking you diabetic foot, you have to tell about sepsis. They will not tell you that can you tell the 1 hour bundle of sepsis. But this is understood that you have to tell about the initial management of sepsis. Okay.
Yes, sir.
So that's what you were telling, 30 ml per kg. But would you like to give in any patient 30 ml per kg stat? Or you will be starting the fluid? You will be starting the fluid, you will be doing the monitoring, you will be seeing the response, and you will be looking at any signs of overload. Why overload? Not only because that patient is dehydrated, only because maybe patient have some underlying cardiac problem, which is which will be changing your management plan. Okay, maybe you would like to have some inotrope to be started earlier.
Yes, sir.
Okay. So you can say that I will be starting the fluid resuscitation and I will be setting some goals. I will be looking at the signs of overload, and then I will change the my management according to the patient. Okay. So that's what they are writing, the dynamic measures to guide fluid resuscitation. Okay. So actually people are very happy to see this, but they may miss this step. Okay. So this is very important thing. And they have written it weak, but actual thing is that this is the most important thing. Okay. But because not on a, not you, it will be unusual to have a young patient in sepsis. The patient who have already have some comorbidities with will have more chances to have sepsis rather than a young patient. Okay. So this is one thing. Then you will be doing the ABGs, lactate, and you will be, that's what they have written. Same thing they have written, okay? That capillary refill and any signs of perfusion. You can say here anything like your physical examination. You can tell about ultrasound. You can tell about journal, for example, if the patient was not intubated, so patient was before conscious level was not good, very good. Now you start the fluid resuscitation. Now the conscious level is improved. So this is a sign that patient is responding to the management you are doing. Okay. So then next step will be that you will be focusing a blood pressure, or what is the other thing which you do other than mean arterial blood pressure? What is that one?
Of course, hemodynamics, heart rate,
Mm,
respiration,
yes,
saturation,
you
and
follow
in
another thing.
resuscitation they say serum lactate.
And one else, what else? There is one is blood pressure, one is the general condition, one is lactate. There is one more thing which is not shown up till now here.
Urine output.
Urine output is there. This is just for journal response. There is one more thing, objective thing which they follow is, think, Mamuna. Then you will say yes, 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 yes. Mixed venous oxygen saturation or jugular venous oxygen saturation. Am I right?
This is the differentiating point from
Yes.
other shocks.
Yes. Okay. So because before they were stressing on mixed venous oxygen saturation, but recently, because pulmonary artery catheter is the only way to take the mixed venous oxygen saturation, so now they rely on even jugular venous oxygen saturation. What is the difference between these two? If someone asks you, what is difference between jugular venous oxygen saturation and mixed venous oxygen saturation?
Sir,
Which is higher relatively?
jugular venous.
The blood coming from superior vena cava and blood coming from inferior vena cava. If we just think this think like that, and then when they reach the ventricles, is there something which is coming extra and which is very
Yes,
deoxygenated blood? That is the blood supply of the heart, which
itself
is
heart. Yes,
mixing
the
it.
Bayesian vein draining. Yes, directly into it.
Okay, so that's why, and that is the most reliable one. Okay, so usually the mixed venous oxygen saturation, if you are targeting, you have to target a little higher. Am I right? Okay. So what else will you do? So you will be starting the antibiotic therapy. You will be starting the vasopressors if needed, in addition to fluid responsiveness. Then you can do, say here that you can have CVP or arterial blood pressure or cardiac output monitoring, whatever facility is there. Okay. And then you will be looking out. They have written something extra, uh, likelihood of infectious versus non-infectious cause of acute illness. Okay. So then again, reevaluating about the treatment which you are giving. Okay. So what other investigation you can do at that time? In addition to culture, this is procalcitonin. I am not very familiar with what is the interpretation. I forgot it. I think it is a sepsis marker for sepsis. What else we can do is CRP, ESR. Okay. And for example, in case of any other specific markers, like for example, if there may be source is hepatic, there will be an elevation of liver enzymes. If the source is, for example, pancreatitis, okay, so there will be rise of that specific enzymes. Okay, so you have to, when they are asking you a question, they are expecting you not to just reproduce sepsis guidelines. They want the clinical management. The clinical management is not only confined to this piece of paper. Okay, so when you are telling about the patient, You have to say that there may be other source. Other source you can label these things. Okay. So these all they have written about antibiotics and everything. And antifungal, antibiotic, they are the use of antiviral not recommended, but again it will be depending on the possible cause. Then they will be looking at the other organ system involvement. What will be that? For example, this patient if is intubated, then there will be considerations related to ventilatory therapies or ventilatory strategies. If there is an element of pneumonia or if there is an element of ARDS, you will be saying that you will be considering the different ventilatory strategies based on the airway pressures and avoiding the biotrauma and barotrauma and or voluotrauma. Okay, you can just say this thing, and then you will be protecting the patient for ventilator associated pneumonia. Even if they have not asked you, in the next step, you can say that you will be doing whatever. We will just look at it in short time, that you will be protecting the patient against VAP. Okay. And the journal care which I discussed yesterday, you will be telling at that. So assessment of de-escalation of antimicrobial therapies according to the situation later on. Okay. So hemodynamic management, crystalloids, first line of resuscitation, then colloids. Actually, yesterday I did not discuss about the blood and blood products. So usually you will be looking at whether there is some cardiac involvement or no. If there is some cardiac disease, you will be trying to aim at a higher hemoglobin level. Otherwise, you can allow even up to 6 or 7. Okay. And the rest of the parameters about for possible nutritional problems or coagulopathy will be directed according to the patient. Okay. If the patient is having low albumin, you will be giving albumin. If the patient is having nutritional problems, any specific ionic replacement is needed, you will be following it. Like, for example, patient may have hypokalemia, for example. So you can give in IV form or oral form according to the situation. Okay, if the patient is taking parenteral nutrition, oral preparation will be better than IV preparation. But if the patient is on sorry, not enteral. Enteral will be better choice. If the patient is on parenteral nutrition IV, then you will have to replace it in that solution. Okay. Just a second. What else? Actually these are not, you don't need to cram each and every, like starches and gelatin are actually not used. Usually albumin is the colloid of choice. Okay. And then we have discussed about norepinephrine and rest of the things. Usually the second choice is epinephrine or vasopressin. Okay. And angiotensin 2 is, I don't think so available. I'm not sure about it. Okay. And whenever you are saying use of norepinephrine or any vasopressor, you can say that it is better to be given through central line, and it is better to have arterial blood pressure monitoring for meticulous control and monitoring of the blood pressure. Okay. What else? What else will you be doing? If even this is not responding to fluid, not responding to vasopressor, what is the third step you can consider in these patients?
Hydrocortisone.
Hydrocortisone. Okay. So you will be doing the starting hydrocortisone. It is better to give an infusion. Okay. And would you like to give mineralocorticoid or glucocorticoid in this situation?
Both.
What will be the use of glucocorticoid? Actually, the main thing is mineralocorticoid. in this scenario specifically. Okay. So we discuss, I just mentioned it, we will just go to ARDS and VAP, and we will try to discuss these things, but usually they will be starting at a low tidal volume, and according to the airway pressures, they gradually increase the tidal volume. Okay. And here they use the word with predicted body weight. I don't have very good concept about it. It is just like ideal body weight, because usually in the calculation of medications and everything, we use lean body weight. Okay. And then you have to get a balance between tidal volume, airway pressures, and allowable PEEP. Okay. You will gradually increase the PEEP, and the other strategies will be prone, intermittent prone positioning, use of nitric oxide, and later on, as a final resort, if nothing is working, then ECMO. Okay. ECMO and jet ventilation. Okay. Okay, yes. And role of neuromuscular blocking agents. Yesterday we discussed that in certain condition, you need to give neuromuscular blocking agents. Like if you want to knock down the patient totally, as in head injury, you don't want the patient to have any stress response. So in that condition, you can use it. And even in ARDS, okay, you can use intermittent boluses or continuous infusion. You can use it. Here they are saying that intermittent boluses are better than continuous infusion according to their. Okay. So we have discussed these things. We just against using polymyxin B, hemoperfusion. I don't know about it. Okay. It's not possible to reproduce each and everything. What they say, we recommend using a restrictive transfusion strategies, as I told you, that if the patient is cardiac, then you can target a hemoglobin of 10. Otherwise, you can go down 6 to 7 up to. Okay. IV immunoglobulins, not without any reason. If there is a specific condition, in which conditions you would like to give immunoglobulins in ICU? We discussed earlier, tetanus, GB syndrome, or any specific autoimmune condition. Otherwise, not, because before they used to give immunoglobulins as a general measure to cope with sepsis. So they are suggesting not to give it. Okay. And what else? Stress ulcer prophylaxis. There is controversy about use of antacids for stress ulcer prophylaxis. Okay. Then other things are glycemic control. We did a mnemonic for it yesterday. Fast hug. F for feeding. I hope this will work now. Feeding. Okay. A for analgesia.
So
S
are you
for
writing? We can.
Is it visible?
Yes, sir.
Yes, sedation. Okay. T for thromboprophylaxis. H for hemodynamic monitoring. U for ulcer prophylaxis. And G for glycemic control. But other, usually all the things, positional strategies like head up, okay, supra glottic suctioning, okay, maintaining cuff pressures and measuring it with the manometer, cuff pressures, okay, selective GIT decontamination, okay, what else? Maintaining the urine output, maintaining intake output, okay, care of lines and tubes, and try to avoid as much as possible. Okay. Specific CVP bundles we discussed yesterday actually. Okay. And similar for tubes. Tubes like Foley's, or NG tubes. Okay. So that's why supraglottic suctioning, I told you, intermittent, intermittent positioning changes. Okay. This is also for bed sores and for prophylaxis of actually venous thromboembolism. Okay. So this is general care which don't forget, because majority, even if you are telling about tetanus, even if you are telling about GB syndrome, you have to mention about these things. Maybe they will be asking you each one in detail, but you should be thinking that if they are asking more, or if you can make a mnemonic for yourself, so that you, whenever, whatever ICU question they are asking you, any patient with ventilation in ICU or without ventilation, you can mention all these things. Okay. And if you have grip on it, then you will find that there are very few specific things which you need to reproduce. Okay. So venous thromboembolism through mechanical or pharmacological. Okay. Then you will be considering acute kidney injury, suspecting acute kidney injury, because if the patient is on high vasopressors, this is also a risk factor. If the patient remain hypovolemic and hypoperfuse, the first thing which will be going even before brain will be acute kidneys. What is the reason for it, Mamuna? Why kidneys shut down before any neurological injury in hypotension or hypovolemia? What is the reason for it?
So due to high metabolic rate and oxygen extraction in
Oxygen
by
extraction. Which organ has the highest oxygen extraction?
heart.
Okay. So that is not the reason. There is auto-regulation.
Okay.
Okay. The auto-regulation of heart is not usually on blood pressure. Okay. There are local methods more. Here, auto-regulation is maintained at 80 to 180. Okay. In the brain, it is around 60 to 160. So that's why kidneys goes before brain. Okay. So whenever there is a hypertension, there will be no urine output. Okay. That's why basic sciences will not let you live in anesthesia. Okay. Okay. So vitamin C, before actually these small things, vitamin C, protein, activated protein C, and things like that, they are always controversial. Okay. There is even use of bicarbonate only if the pH is less than 7.1. You see, just to improve the hemodynamics or to reduce vasopressor, it's not required. Okay. We suggest against using pseudomycin. That's what they are telling. Only if the pH is less than 7.1. Okay. And yesterday I also about the use of THAM solution. If you have this is a alternative for soda bicarb. Okay. This is also to treat acidosis, but it does not have sodium and it does not cause volume overload. Okay. So they can ask you about it. What else? Early start of enteral nutrition. This is most important thing. What is the problem if you don't start enteral nutrition?
Patients' mortality and morbidity will be increased by
Why?
because of more risk of infectious complication and the transmural
Yes, very good.
uh,
Translocation of bacteria, overgrowth of
bacteria
the
from the
bacterial flora.
GIT.
Okay. So this is one of the cause of, and because you are using another reason for it, especially if these patients are receiving vasopressors,
Critically.
there is already ischemia. Okay. So the ischemic gut, there is necrosis and there is more chances of membrane damage and more chances of patient going in sepsis. Okay, that's why monitoring lactate levels are important, and similarly start of the of the this enteral nutrition is that's why it is important, because if the patient is going in catabolism, then there are more chances of infection there. The body immune system will be even more further depressed. Okay, and these are the things related to the counseling and the consent issues. And if another thing related to hair will be that if, for example, if your patient is going towards organ failure, and now or patient is all going towards brain death, for example, so you will be considering about organ donation in that specific scenario. So just keep this thing in your mind. Sometimes they make a question like I was asked about brainstem death and organ donation from a patient. They said that there was a cardiac arrest out of hospital, and then they make the patient in ICU. After the management, they took me towards the maintenance of the organs, confirmation of brainstem death, and involvement of the organ transplant team, and then what replacements you need to give when you are securing a patient for possible organ donation. Okay, so this is a question which may be asked in the exam. Okay, so I think these are all this logistic stuff they are telling. Okay, so the rest of the things are repetition actually. Okay, so the bad when you read this article, try to have have a look on these charts. Okay, so like dynamic parameters response to a passive leg rest test or a bolus using stroke volume where available, or echo where available. So things like that, you will have a better concept. But don't forget, then when they are asking you in the exam, you don't have to only reproduce this piece of paper. You should be reproducing the care of the patient. Okay, so some words about ARDS. Acute, whenever there is a topic, there is some predisposing factor. This is one thing, and it is an acute condition which is resulting in inflammatory increase, exaggerated inflammatory response, resulting in opacities of hypoxemia. Okay, there is dead space, so there will be development of hypoxemia. Okay, and whenever the lung tissue is damaged, the compliance will be decreased. So that's what is the concept of. Before they used to identify a cardiac problem, but now they are saying that cardiac problem can be there in a patient with ARDS. So they don't want to differentiate, because before they used to keep this pulmonary artery occlusion pressure in its definition, but it was removed in this Berlin definition. Okay, and before they used to say only chest X-ray, but later on they also added CT scan in it. Okay, so it's an acute with a trigger, and there is hypoxia with PF ratio. How to calculate? If I give you example, the PO2 is 60 with the FiO2 of 60%. So how much will be PO2? How much will be PF ratio? Because
100,
how do you calculate it?
100,
So it was 60%
100
FiO2 and
FIU, you told
60
me
millimeter of mercury PO2. Okay, so you will take it as 60 as P and 0.6. So it will be 100. Okay, it's like that. Similarly, for example, if we have a PO2 of 100 on 0.2%, so that's why our PF ratio is around for 500. So we just, if it is less than 300, it is mild ARDS. If it is less than 200, it is moderate ARDS. And if it is less than 100, it is severe ARDS. Okay. Then what else? That's what is written here. we have discussed a number of things. There is inflammatory process, TNF, and then there is mucosal damage. Okay, inflammatory markers will be increased, and then what happens? Proliferative phase, and then later on, the role of steroids is in the fibrotic stage. Okay, and actually that time it is making the patients away from recovery. Okay, if it is too much fibrosis or too much response occur, and initial there will be two stages which are dangerous. If the patient survives from acute phase or from the recovery phase, in these two phases actually more problems can occur, so you have to be very careful. Okay, these are the precipitating factors. They can ask you, even if you have a patient with you are discussing about transfusion reactions, so you have to tell that these patients may develop ARDS. Similarly, any other precipitating factor, like in polytrauma, they don't tell you that you have to tell about ARDS, but you know that this is one of the cause of ARDS in young patient, because in young patient, that patient will be COPD or aspiration, or usually not like that, unless there is some trauma. Okay, so think about it, try to memorize, don't try to cram the list, because you will forget. If you understand, then it will be easier for you. Okay, so okay, so ventilatory strategies, I told you that they are saying that start with 4 to 6 ml per kg and gradually building up. What is difference between plateau pressure and peak pressures, peak airway pressures and plateau pressure? Yes. What is difference? Anika, you can tell what is difference between peak pressure and plateau pressures? Plateau pressure is showing the static compliance when there is no airflow. And the peak pressure is because of dynamic compliance, when the maximum airflow is occurring. So usually when you are dealing with ARDS, you are monitoring the plateau pressures. And when you are dealing bronchospasm, you are dealing with peak pressures. So this is a little bit of difference. Okay. So the basic mechanism is that you have to titrate the tidal volume, airway pressures, permissive hypercapnia, and targeting a specific pH with addition of PEEP. If you forget, you just can tell like that. There are so many tables, but the basic principle is that you will be starting with a lower tidal volume. You will be looking at the pressures, and if you are within that pressure limit, then gradually you will increase the tidal volume. And if it is not responding, then you will add PEEP. And still there is some problem, you will be allowing a little bit of hypercapnia at cost of avoiding increased airway pressures. This is the basic principle about it. Okay, so that use of PF FiO table titrating based on plateau pressures, the stepwise increase until maximum compliance occurs, recruitment maneuvers followed by decremental titration based upon the inflection point of the pressure volume curve. Okay, so prone ventilation is one of them, because in this, the areas of lungs which are not ventilated in the supine position, when you are making the patient in intermittent prone, then this will be occurring. Okay, inverse ratio is also there, because in inverse ratio, actually inverse, you are increasing the inspiratory time. But what is the problem, that if the patient is retaining CO2, then it will be a relative problem for you. It will become a challenge. High frequency oscillatory ventilation is principle is with the pressure oscillation with the diffusion. This gas exchange is occurring. Okay. These recruitment maneuvers actually are tricky because they itself can cause injury. So you have to be very careful when you are doing this. And the last thing, as I discussed with you, is ECMO and nitric oxide. Inhale nitric oxide, inhale prostaglandins, prostacyclins. Okay. So whenever they are asking you the topic, they will be starting from any inciting factor what is the definition, how to diagnose it, what are the challenges which you will be facing, and how to do the achieve the ventilation in this patient. Okay. Similarly, actually, this pneumonia may be hospital-acquired pneumonia, community-acquired pneumonia, and the type of hospital-acquired pneumonia which is occurring after initiation of ventilation or after cessation of ventilation. Okay, so this is even where the patient had intubation and now he's recovered. This ventilation is stopped, but still you can develop. Just a second, please.